Good morning. This is Dr. Handrada. I'm here today with Alex Mungarian. Today, we are going to continue talking about sleep and how sleep deprivation can precipitate a manic episode and the pathophysiology behind it. The last video, we talked about the role of adenosine. Uh, and as we all know by now, adenosine usually accumulates when you are awake for a long period of time, and it's usually responsible for the homeostatic sleep drive. So, as you're awake, adenosine accumulates, and we know that it acts on adenosine A1 and adenosine A2A receptors. We talked about adenosine A2A receptor, which forms an heteromer with the D2 receptors in the striatum. But we talked about the A1 receptor very briefly, right? We basically mentioned that the A1 receptors, when you basically stimulate it with adenosine, it can decrease the release of glutamate, and it can suppress wake promoting areas in the brain, and thus causing slow wave sleep, which is the restorative sleep where you have memory consolidation and um, the rearrangements of synapses. Now, another function of the A1 receptor is, so if you look at cortex, so we have the cerebral cortex, which has pyramidal neurons and GABA interneurons. The pyramidal neurons of the cerebral cortex projects into the striatum, right? And the striatum has cholinergic interneurons. So we talked about cortex, which sends pyramidal neurons into the striatum, right? Striatum is your basal ganglia. And these projections from the cortex to the striatum is called as the corticostriatal pathway of projections. And the nerve terminal here is rich in adenosine A1 receptor, right? Let me draw this in red. So it's, and then in the striatum, we also have got cholinergic interneuron, which is CIN, which is usually responsible for the release of acetylcholine. And this cholinergic interneuron is like a pacemaker in the striatum that controls the release of dopamine into the striatum, right? And as we all know, dopamine usually helps to color things in life, right? So when dopamine is released into the striatum, it's going to encode that particular stimulus from the cortex in terms of prediction error, right? It's going to actually tag the stimulus based on the motivational value of the stimulus to let you know whether you're going to go on with an action or you're going to stop an action, right? Now, the dopamine that is poured into the striatum usually comes from dopaminergic neurons present in the brainstem. So, one of them is the ventral tegmental area, and these are usually responsible for the mesolimbic pathway. As the name suggests, meso means midbrain and limbic is the limbic system. So the neurons from these areas usually project into the striatum, and they usually project to the nucleus accumbens, that is a ventral striatum, which plays a very important role in reward processing and motivation, as well as it also projects into the dorsomedial striatum. And we're going to talk about dorsomedial striatum when we talk about psychosis and schizophrenia, because when you increase dopamine in the dorsomedial striatum, it can lead to psychotic symptoms because now you're tagging neutral stimulus. You're giving an abnormal salience to a neutral stimulus that is responsible for hallucinations or delusions. All right. We're not going to focus on this. I just want you guys to remember that ventral tegmental area is a dopaminergic center in the midbrain that is responsible for the mesolimbic pathway. So it projects into the striatum. All right. Another dopaminergic center is substantia nigra pars compacta, which is written as SNC. And we all know that this is responsible. This is the striatonigral pathway. Right? We have heard of this in Parkinson's disease or movement disorder. This will also project into the striatum, and they usually go to the dorsal striatum, which is responsible for the motor control, right? Now, these dopaminergic nerve terminals are rich in nicotinic acetylcholine receptor, right? One of them is called alpha 4 beta 2 nicotinic acetylcholine receptors. So when you stimulate them, you cause the release of dopamine, right? And we know that dopamine will then act on the medium spiny neurons in the striatum. And there are two kinds of medium spiny neurons in the striatum, one that is rich in D2 receptors, which form the indirect pathway, which is also called as the no-go pathway. That means that when you stimulate the indirect pathway, you inhibit a particular movement. Another group of medium spiny neuron is rich in D1 receptors. These are called as the direct pathway. This is called as the go pathway. Stimulation of this helps you to go forward with the movement, right? The cholinergic interneurons that we are talking about here is rich in NMDA receptors. So if you look at the corticostriatal pathway, so when they are stimulated, it causes the release of glutamate. Glutamate will act on the NMDA receptors, causing the release of acetylcholine. And the acetylcholine will then act on the nicotinic acetylcholine receptor to cause the release of dopamine, right? So this is how dopamine is released into the striatum. Now, when adenosine acts on the A1 adenosine receptors, right? And A1 adenosine receptor is coupled to GI protein. That means that it has, when you stimulate it, it inhibits the release of neurotransmitter or electrical activity. So when adenosine acts on the A1 receptor, what happens is that you prevent the release of glutamate. If glutamate is not released, then it also decreases the release of dopamine, right? And we all know adenosine, the function of adenosine is to help with the slow wave sleep. So when you're sleeping and when you're in slow wave sleep, you do not see any limb movements, right? And we know that in patients with bipolar disorder, even in euthymic state, there is a decrease in the adenosine, right? Because of the increased catabolism. And we talked about like how xanthine oxidase inhibitor like allopurinol can actually help uh, restore the adenosine level, because it usually leads to accumulation of the intermediate products, which is then converted into adenosine. So in patients with bipolar disorder, when the adenosine level is decreased, then your A1 receptors on the corticostriatal nerve terminal is not stimulated. So you basically have the release of glutamate, which acts on the NMDA receptors on the cholinergic interneurons, which releases acetylcholine, which acts on the alpha 4 beta 2 nicotinic acetylcholine receptors on the dopaminergic nerve terminal, increasing the amount of dopamine, right? And which in turn is responsible for increasing the wakefulness. So we know about how adenosine plays a role in insomnia and the precipitation of manic episode. Now we'll talk about another compound which is called as allopregnanolone, which we will refer to as AP. And we have heard of allopregnanolone, right? Especially in patients with postpartum depression. We'll touch base on postpartum depression a little bit actually while we are talking about allopregnanolone. So allopregnanolone is basically produced from progesterone. And at the start of this video, we talked about a case vignette of a pregnant female who develops postpartum mania. So progesterone is basically produced from placenta as well as corpus luteum. This produces progesterone, and then progesterone is converted by 5-alpha reductase into allopregnanolone. what's the function of allopregnanolone, right? Now, allopregnanolone is basically produced because when you're under stress, insomnia is a kind of stress, there's an increase in the free radical and reactive oxygen species in the prefrontal cortex. And one of the functions of allopregnanolone is to neutralize these free radical or reactive oxygen species, preventing neurotoxicity. All right. Allopregnanolone basically acts on GABA A receptor, right? But there's a difference. So if you look at a nerve terminal here, and you have the postsynaptic surface is this here, right? Now, these postsynaptic nerve terminals, let's consider them, they have GABA A receptors. So the GABA A receptors can be present within the synapse and outside the synapse. So it's called intrasynaptic and extrasynaptic. So within the synapse, there are two different types of GABA A receptors. One is which has a gamma subunit, another one which has delta subunit. Gamma subunit is something that benzodiazepines attach itself to. And the delta subunit is where allopregnanolone will attach. Now, the gamma subunits are present only within a synapse. They are responsible for something called as phasic inhibition. Whereas the delta subunit is responsible for tonic inhibition, the baseline. Right? And most of the inhibition that happens is tonic inhibition, right? Unless there is a stimulus, which is behaviorally relevant or salient. The the delta subunits are also present extrasynaptically, right? And this extrasynaptic delta subunit is responsible for tonic inhibition. So allopregnanolone will attach to the delta subunit of the GABA A receptor, both within the synapse and outside the synapse. So now let's talk about allopregnanolone. So sleep deprivation, and we call the sleep deprivation here as SD. Let me select a perfect. There you go. So we'll call sleep deprivation as SD, right? So what sleep deprivation actually does is that it will cause an upregulation of 5-alpha reductase activity. And as we know, increased activation of the 5-alpha reductase will increase the conversion of progesterone to allopregnanolone, right? And this increase in the allopregnanolone is usually happens in the prefrontal cortex. All right. So in the prefrontal cortex, we have pyramidal neurons, right? So this is the cell body, and this is the proximal axon, and this is the dendrites, right? So we have the pyramidal neurons, which are glutaminergic in nature, and around the pyramidal neuron, or the firing of these pyramidal neurons, are controlled by GABA interneurons. And there are plenty of GABA interneurons. So one of the GABA interneurons is the parvalbumin positive GABA interneurons. Okay, so it's written as parvalbumin positive GABA interneuron. Right? We'll just erase this. All right. Now this forms a synapse at the cell body and the proximal axon. So what it usually does is that it usually controls the outflow of information. And the parvalbumin is also responsible for the signal to the noise ratio, right? More signal is better with less noise. Then you have got another type of GABA interneuron called as the somatostatin GABA interneuron, somatostatin. Now, this somatostatin GABA interneuron usually forms synapse with the dendrites. So it usually controls the inflow of information, right? So the main function of these GABA interneurons is to synchronize the firing of the pyramidal neurons. So if you take away the GABA interneurons and you just have the pyramidal neurons, then you usually see an asynchronous firing of the pyramidal neurons, right? So the GABA interneuron will synchronize it so that all the pyramidal neurons will fire together. And that is responsible for creating something called as the gamma oscillation. And this gamma oscillation plays an important role, especially in attention, in working memory, as well as in sensory motor gating, right? There's another group of GABA interneuron called as the VIP, vasoactive intestinal peptide, also called calretinin, whose main function is to put a brake on these other GABA interneurons, especially the somatostatin, but also the PV positive or parvalbumin positive, right? So they modulate the functioning of the GABA interneurons. Now, when we're talking about allopregnanolone, as we know, allopregnanolone is a positive allosteric modulator at the GABA A receptor, especially the delta subunits, right? And the parvalbumin positive GABA interneurons are rich in the GABA A receptor, which has the delta subunit. So when allopregnanolone is released, it acts on the delta subunit of GABA A receptor. So what will it do? When it acts on this, it will inhibit the parvalbumin positive GABA interneurons. So when you inhibit it, you're not able to put a brake on the soma and the proximal axon or the pyramidal neurons. So this will disrupt the signal output. All right. And as we know that the firing of the pyramidal neuron are synchronized by the GABA interneurons, especially the PV positive, which is also called as the fast spiking interneurons. This will cause the asynchronization, the desynchronization of the pyramidal neuron firing. It will affect the gamma oscillation, which in turn can affect your attention, your working memory, and the sensory motor gating, right? Which is not good. And so what happens now? Now, this particular phenomena usually happens in the ventromedial prefrontal cortex. And the ventromedial prefrontal cortex in the animals is called as the infralimbic prefrontal cortex. And we'll talk about it in more detail when we talk about schizophrenia, is that if there is a decrease in the functioning of the ventromedial prefrontal cortex, there will usually be an increase in the release of dopamine in the basal ganglia or the striatum. So now, so we know that since the parvalbumin positive GABA interneurons are inhibited by allopregnanolone, the firing of the pyramidal neuron becomes more asynchronous, which affects the gamma oscillation and therefore the attention, working memory, as well as sensory motor gating. All right. Now, a problem in these domains are also seen in patients who are manic. All right. So in pregnancy, what happens is, so before pregnancy, the level of allopregnanolone is usually about 5 nanomoles per liter. But in the third trimester of pregnancy, when the placenta and the corpus luteum is producing a lot of progesterone, the level of allopregnanolone increases by to 157 nanomoles per liter. So that is about a 30 times increase in the level. All right. Now, we'll come back to this. So when the allopregnanolone inhibits the parabolic positive GABA interneuron, that are fast spiking GABA interneuron, it usually decreases the activity of the ventromedial prefrontal cortex, right? Because for a prefrontal cortex to function properly, the GABA interneuron should be firing in a very synchronous manner. Otherwise, it usually disrupts all the downstream pathway from the ventromedial prefrontal cortex. So the ventromedial prefrontal cortex, what it does is normally, right, in a healthy control, is that it usually acts on the reticular thalamic nucleus, which is a nucleus present in the thalamus, and its main function is inhibiting other thalamic nuclei, right? So this is GABAergic in nature, the reticulothalamic nucleus. The reticulothalamic nucleus, what it does is it usually puts a brake on the midline thalamic nucleus, which are glutaminergic in nature. Okay. The reason I'm explaining this is to let the audience understand how ventromedial prefrontal cortex controls the release of dopamine from the ventral tegmental nucleus, which is a dopaminergic center in the brainstem, which in turn is responsible for the mesolimbic pathway. All right. And it's good to know it now because we are going to talk about this pathway when we are talking about schizophrenia or psychosis. The midline thalamic nucleus, what it does is that it stimulates. So if you see an arrow, that means that it stimulates. If you see an arrow which has a flat tip, that means that inhibition. All right. So the midline thalamic nucleus, it will stimulate the hippocampus. Hippocampus also has pyramidal neurons. The structure of the hippocampus, the cellular architecture of the hippocampus, very similar to that of cerebral cortex, except cerebral cortex is 6-layered and hippocampus is 3-layered. All right. So the hippocampus, when it's stimulated, it will, the pyramidal neurons, which is glutaminergic, will stimulate the nucleus accumbens, which is the ventral striatum. And the nucleus accumbens is GABAergic in nature. So when you stimulate it, it inhibits ventral pallidum. Ventral pallidum is GABAergic in nature. All right. And ventral pallidum, when it's functioning normally, what it does is that it inhibits the dopaminergic neuron in the ventral tegmental area, which is the dopaminergic center in the midbrain, in the midbrain. So let's look at the entire cascade again. What happens? So when the allopregnanolone is released during the third trimester of pregnancy, which is about 30 times the pre-pregnancy level, it will inhibit the paralbumin positive fast spiking GABA interneurons in the prefrontal cortex, which causes the asynchronous firing of the pyramidal neurons and thus decreasing the activity of the ventromedial prefrontal cortex. If the ventromedial prefrontal cortex activity is reduced, then it's not able to stimulate the reticular thalamic nucleus, which are GABAergic in nature. If you cannot stimulate the reticular thalamic nucleus, you cannot inhibit the midline thalamic nucleus. So now the midline thalamic nucleus is activated. It's glutaminergic in nature, so it will stimulate your hippocampus. And the hippocampus, in turn, will then stimulate the nucleus accumbens, which in turn will inhibit ventral pallidum. And the ventral pallidum then is not able to inhibit the dopaminergic neurons in the ventral tegmental area, causing an increase in the release of dopamine into the striatum or the basal ganglia. And as we all know, increase in the dopamine in the striatum is going to increase the psychomotor activity as well as arousal, right? And that is how allopregnanolone actually plays an important role in increasing the release of dopamine. Now, the dopamine that is released is not just in the striatum, but dopamine is also released in the prefrontal cortex. All right. Now, we know that the function of dopamine in the prefrontal cortex is to help with working memory. All right. So let's go back to the prefrontal cortex and let's look at how does the dopamine actually work here. So we have the pyramidal neurons, then we have the parvalbumin positive GABA interneurons, which form synapse on the cell body and the proximal axon. We have the somatodendritic GABA interneurons, which form synapse especially with the distal dendrite, right? We have the VIP neurons, which usually inhibits the somatostatin neurons, right? Now, the dopamine receptors are present on the pyramidal neuron as well as the GABA interneurons, all right? So these are D1 dopamine receptors. So if you look at D1 dopamine receptors, they are D1, D3, and D5 dopamine receptors, right? And D2 like dopamine receptors are D2 and D4. These are autoreceptors, D2. So you have this D1 dopamine receptors on these GABA interneurons, right? But the VIP neurons, the VIP neurons are rich in D5 dopamine receptors, whereas the parvalbumin is rich in D1 dopamine receptors. All right. And we also know that the parvalbumin also contains the delta subunit of GABA A receptor, which is acted on by allopregnanolone. Now, the dopamine that is released in the prefrontal cortex will first actually activate the D5 dopamine receptor on the VIP neurons because the D5 has 10 times increased affinity for dopamine as compared to D1 receptors. So when you activate the D5 dopamine receptors on the VIP GABA interneurons, it will inhibit the somatostatin neurons. So you'll have increase in the inflow of information to the pyramidal neurons. Now, on the other hand, the dopamine will also act on the D1 receptors. So when you act on the D1 receptors on the PV positive, it should stimulate the PV positive GABA interneuron, which in turn should actually resume its inhibition on the pyramidal neurons. But what happens is that when your allopregnanolone level is 30 times the pre-pregnancy level, it acts on the delta subunit of GABA A receptors. So the dopamine that is released is not able to activate the PV positive GABA interneurons. And thus it's not able to synchronize the firing of these pyramidal neurons, causing a disruption in the gamma oxylation. Right? So the function of the prefrontal cortex is disrupted, and the dopamine that is released in the prefrontal cortex is not able to bring it back to homeostasis. Right? Same thing actually happens in the amygdala, because amygdala also has parvalbumin positive GABA interneurons, which control the firing of the pyramidal neurons in the basolateral amygdala. And here it disrupts something called as a theta oxylation, which is responsible for emotional regulation. So when it affects the amygdala, you see an emotional dysregulation that is a typical thing that is seen in patients with mania, emotional dysregulation and the mood instability that you actually see. So there are three things happening now here, right? So one is you're disrupting the function of the ventromedial prefrontal cortex. Thus, you're increasing the release of dopamine. The dopamine is not able to bring the prefrontal cortex back to homeostasis. At the same time, allopregnanolone is also affecting the amygdala, which in turn is affecting the emotional regulation. So, the allopregnanolone that is produced is not just in pregnancy. You also see that in not just in female patients, but also in men, right? So, sleep deprivation stimulates 5 alpha reductase, and thus it causes an increase in the production of allopregnanolone, which is a positive allosteric modulator at the GABA A receptor, which has the delta subunit, which is responsible for phasic inhibition, especially it acts on the extrasynaptic one, right, which is responsible for phasic inhibition. And increase in the allopregnanolone, as we all know now, causes decrease in the functioning of the ventromedial prefrontal cortex. Decreased functioning of the ventromedial prefrontal cortex causes an increase in the release of dopamine, right? This increase in the dopamine, when it happens in the nucleus accumbens, which is a reward center of the brain, leads to increase in the reward seeking behavior, right? You see all these reward seeking behavior in patients with mania who spend thousands of dollars, who basically get involved in erratic sexual behavior, right? Increase in the dopamine in the prefrontal cortex usually relates to the antidepressant effect, right? And manic patients are not depressed, they're euphoric or they are irritable. And the increase in the dopamine in the dorsal striatum leads to increase in the psychomotor activity, right? So allopregnanolone increases dopamine. When it's increased in the nucleus accumbens, reward seeking behavior, increase in the prefrontal cortex, the antidepressant effect or the euphoric effect, an increase in the dorsal striatum leads to increased psychomotor activity. Same way, allopregnanolone, when it affects the basolateral amygdala, it can lead to emotional dysregulation, as well as mood instability, right? And we all know that postpartum period increases the risk of precipitation of mania in patients who have a predisposition for bipolar disorder, all right? And one of the medication that we commonly use in postpartum depression is zuranolone, which is a positive allosteric modulator of the delta subunit of GABA A receptor at the extrasynaptic site. So this is about how sleep deprivation increases allopregnanolone and the role of allopregnanolone in men and women in precipitation of mania. Thank you.